Hey everybody, I decided today is a great day to talk about opioids because why not? First off, I want to just make a quick vocab distinction before I drive myself insane. So, when we talk about opioids, we are sometimes using interchangeably a term of opiates. You probably heard that. Technically, when we say opiates, those are derivatives from the crude opium, which comes from the opium poppy. Those include substances like codeine and morphine. Those are true opiates, and they're true agonists for the receptors that opioids bind to. Opioids are synthetic forms of opiates, meaning that they are things like codeine and morphine that have been altered in some way for binding capabilities. Whenever you see oid in science and medicine, it means kind of like something. So opioids are kind of like opiates. So there's that. All right, let's get started. All right, so regardless, opiates, opioids, we know that this class of medication is associated with analgesia or the blocking of pain. So before we get into the pharmacology of opioids, let's just do a quick little physiology primer, starting really simple. In order to perceive pain, we have to have a receptor receive that painful stimulus and then carry forth that information to the brain so that we can literally perceive it. So, sensory information, like most other things, it travels in this pathway that involves these neuron chains. So that means there's a receptor somewhere, not outside of your body, but like this is on your skin or embedded in your skin. So we've got these different receptors, and I'm going to use the term neuron and nerve kind of interchangeably. I'm going to try to just say neuron to make life easier. But we have these receptors embedded in the skin, and those receptors are associated with a neuron. And these messages travel in what we call neuron chains, meaning that there's a couple of neurons that talk to one another. So we have information coming in from a sensory neuron getting together with another neuron that's going to travel up further to carry forth this message. And then there is a final third neuron, which is going to bring that information up to the parts of our brain that lead us to perceive things. So we're going to be talking about these pre and postsynaptic types of receptors, pre and postsynaptic neurons. Remember, a synapse is just the space between an axon and then the next neuron. So it is the space between. So 1, 2, 3. 3 neurons, a chain system. Opioids are going to interfere with this traveling of information from the sensory receptor up to the brain. So here's a little schematic that shows just a nice drawing of what the system looks like. So we've got a sensory neuron, as I mentioned, embedded in the skin. With pain specifically, we are talking about what are called nociceptors. So they are sensory neurons that are firing when there's a painful stimulus. So that first neuron, which involves that initial sensory receptor, that travels with that message into an area of the spinal cord. If you remember your physiology, sensory stimulus, it enters the cord, the dorsal region. This little thing, this guy here, we call that the DRG, the dorsal root ganglia. So sensory information comes on in the dorsal roots, and the first neuron number 1, terminates on the anterior horn, the gray matter within the spinal cord. So this is our presynaptic cell. This is our first order neuron. The postsynaptic, or after the synapse neuron number 2, picks up at that termination point, decussates or crosses over to the other side of the spinal cord, the contralateral side, and then travels just in a simple ascending fashion straight up the spinal cord through the levels of the lower brain, like the medulla. You can say medulla. You can say medulla, say it however you want, just say it with confidence. And because it's sensory information, not only does it come in on the dorsal side, it also is going to make a stop at the thalamus. All sensory information, besides smell, that's another story, is going to make a stop at the thalamus. From the thalamus, we pick up then with the third order neuron, which is going to go out to the sensory cortex, which is the part of the brain that literally is going to help us perceive that pain. Perceive that pain so that we can tell where that pain is, how bad that pain is, and what we have to do with our body to limit that pain, prevent that pain, make decisions about that pain. So 1, 2, 3, 3 neurons. Opioids are going to affect this traveling of the message through these 3 neurons up to the brain. All right, let's start as simple as we can. So here we're just doing a close-up of that presynaptic, postsynaptic neuron. This is, let's say that's neuron 1 coming from the sensory receptor. Here's neuron 2 picking up in the spinal cord. Typically, when there is a painful stimulus, so pain, ow, the sensory receptor fires. There's 2 different types of pain really quickly. Man, I'm going to backtrack. Fast pain, slow pain. 2 similar systems, 2 kind of similar types of pain. Fast pain is an initial pain with an injury. So if you picture yourself hitting your elbow on something, that initial like, ow, that's fast pain. And that's associated with glutamate. Slow pain is that throbbing afterwards where you're like, man, that hurt my elbow really bad. And you like rub your elbow and it continues to throb. That's slow pain. And that involves substance P. P for pain. Not really, but easy for you to remember. Easy for me to remember. So when there's a painful stimulus, that causes an action potential in this first neuron. And when there is an action potential, that means there's positive ions coming into the cell. And then we get some sort of vesicle with a neurotransmitter moving to the synapse so it can dump out that neurotransmitter into the synaptic cleft. In this case, we're talking about pain. So again, we've got our substance P. When substance P binds to its receptor, those receptors can open, they're channel type receptors, and they can let in ions. And if those ions are positively charged, then we have an action potential in this cell, and then we carry forth this painful stimulus. So up here, we've got opioid receptors. That tells us that when there's opioids on board, we can interfere with the system. So let's follow this picture again. So typically substance P would be released after an action potential from this first order neuron. Substance P would bind to its receptors. We would get positive ion influx. We would get another action potential, and we would get the painful stimulus message traveling up through this 3 neuron chain system. When opioids are on board, they interfere with this. They interfere with it both presynaptically, where they decrease the amount of neurotransmitter release, that's our substance P, and then postsynaptically, these can affect the charge of the second order neuron, making it less likely that they carry forth an action potential. All right, so that's the simple schematic. This is presynaptic, postsynaptic. All right, let's get into the physiology. So opioid type receptors, like we saw the picture of an opioid receptor on that prior schematic, that's a class of receptors with different subtypes. And generally when people are speaking about opioids, they're referring to things that bind to this mu opioid type receptor. However, there's a couple more different types. For simplicity's sake, let's just keep it. There's a mu, there's a kappa, there's a delta, there's a nociceptin one. There's a couple more, and then there's subclasses of those too. So let's just keep it simple and know that today we're going to be speaking mainly about mu opioid receptor agonists. Things like morphine, those are pure mu opioid receptor antagonists, meaning that they bind to that receptor type, they turn it on, and there's some sort of activity. There are these different types of receptors, though, and each of those are associated with different effects because they're located in different parts of the body. Like mu1, those are analgesic type receptors, and they also make you feel really good. Mu2 are associated with more like GI effects, like feeling nauseous or throwing up, and they're also associated with respiratory depression. So there's these different receptor types. We have mixed agonists, antagonists. There's complicated pharmacology to go along with this, but that's our first step. So when we're thinking about those opioid receptors pre and post synaptically, today we're talking about those being mu opioid type receptors. Okay, here is the fun part. Here is the hard physiology. This is the fun stuff, guys. So let's just orient ourselves. Where are we in this picture? So here is our pathway, our 3-neuron chain pathway, our sensory receptor coming in through the DRG, and then 1, 2, 3 are different chains. So here we've got our first order neuron, and then we've got our second order neuron. So remember, opioids, they have presynaptic and postsynaptic effects. So let's find our opioid receptors and go from there. All right, look, I found one, mu opioid receptor. So here's our presynaptic neuron. And at the level of the first order neuron, the presynaptic neuron, when there is an opioid drug that binds to a mu type receptor, that medication, that substance, has a direct effect on the calcium channel at the level of like the bottom of the axon hillock. If you remember from action potentials in general, in order for neurotransmitter that is contained within a vesicle, in order for that vesicle to move to the wall of the axon so that it can fuse with the membrane and dump out its contents through exocytosis. In order for that whole process, the docking and fusion to happen, we need to have the opening of these calcium channels and that calcium into the cell. Calcium, 2 pluses. It's a positive ion. It opens when there is an action potential that spreads all the way down that cell. They're voltage-gated channels, and they pop open, allowing the influx of positive calcium, which allows the docking and fusion of those vesicles so that the neurotransmitter can be released. So that means if a mu agonist binds to its receptor and stops calcium influx, we do not have the ability to dock and fuse this vesicle. So that means we're not going to have substance P contained in its vesicle moving to the end of the axon and then spilling out into the synapse. So presynaptically, we inhibit or we decrease substance P or general neurotransmitter release by blocking that calcium channel. All right, erase that. So now we've got the second order neuron. So that is going to affect that traveling of information from the level of the cord up to the thalamus. So when there are neurotransmitters that bind to their receptors and open up a channel and let things like sodium in so that we can have a positive cell that can then have an action potential because of depolarization, we can inhibit or interfere with that process with opioid receptors being stimulated postsynaptically. When an agonist binds to the postsynaptic receptor, it has direct effects on a potassium outflow channel. Potassium is a positive ion. If this cell is at a charge like right here and we need to drive that charge up so that we can fire, if we have positive ions leaving the neuron, then that is going to drive the charge down. So instead of depolarization and then sending on of a message, we have hyperpolarization, which is going to inhibit that signal from going on. So if we have hyperpolarization, we cannot spread that message throughout the rest of the neuron. We're not going to open up subsequent sodium channels to carry forth that message. We're just going to stop it right there. So we would say presynaptically, mu agonists, so opioids, prevent the opening of the calcium channel and calcium influx, and then vesicle docking, fusion, release of neurotransmitter. And then postsynaptically, they hyperpolarize the neuron by allowing positive ions to leave the cell. So that is our physiologic activity that allows opioids to inhibit these processes. So finally, where these receptors are located determines a lot of their effects. So if you remember that little table I showed you, we've got mu, we've got delta, we've got kappa, and they're associated with different effects. These are just mu receptors in this picture, and they are located all over the body. Where they are located determines a lot of their effects. So you see them up in places in the brain that helps us literally perceive pain, but we also see them in lower brain areas that are responsible for respiratory rate. So not only do we get mu receptor stimulation of analgesia, we also get depressed respiratory rate. We see them along the spinal cord, which is great. That's another way that we can depress pain signals so that we stop the message going up to the brain that there is pain to begin with. However, we also see them located in places like the esophagus, the pylorus, different levels of the intestine. And when we're thinking about their location in the GI tract, those are what drive the effects of things like vomiting, but also constipation. Right? So one of the main side effects of these drugs is that they cause huge amounts of constipation, and they can be leveraged for that, but you have to know that that's a side effect that's predictable. And all of these effects are associated with just location of receptors. We need receptor stimulation, and wherever those receptors are going to determine what they do. So yeah, that was it for today. So those are your opioid agonists. So those are things that bind to receptors that stimulate analgesia. In further videos, we'll talk about antagonists. So one of the ways that we can reverse negative side effects like respiratory depression, which can lead to stopping of breathing, which is what you see with an overdose. We also have pure antagonists that can block those receptors and then displace bound opioids so that we can do things like restore breathing. And you've probably heard of Narcan, a drug called naloxone. That is an opioid receptor antagonist at the mu receptor. So we have lots of different medications. I hope you learned something, and I hope you stay smart.